ahead.
So I guess we will. I'll introduce myself. My name is Khal Aljerian, and I am a pathologist at Alberta Precision Laboratories, which is I guess a division or a unit within Alberta Health Services, and I am affiliated with the University of Alberta through the Department of Laboratory Medicine, and also as a adjunct professor with the John Dossiter Health Ethics Center, and I enjoy doing autopsy, cardiovascular pathology, and some ethics, especially that regarding laboratory medicine. Yeah, so, and then maybe we can go around and introduce ourselves again.
Hey everyone, my name is Daniel, and I'm in my 5th year. I'm doing some extra classes. I do have a degree in psychology, and I think I do have like a wide variety of interests. I think I've been leaning towards dentistry, kind of, and oral pathology, and oral physiology in general. So, yeah.
Hi everyone, my name is Georgiana. I'm in my last year of my psychology degree. I think that pathology is really interesting, and laboratory medicine, I've learned a little bit about it through cell biology and that aspect, but I'm excited to hear today's lecture.
Hi everyone, my name is Nick. I'm in my 2nd year of my MD Master's degree, where I'm currently in my Master's of Pharmacology.
Amazing. So we have a lot of knowledge in this room between all of us. Maybe a little bit seen in a different aspect from each of us. So let's see. Yeah. So I'd like to call the autopsy the final consultation as far as healthcare consultation or healthcare diagnosis, as this is most likely the last procedure that anyone could have happen. And today we're going to talk about the future of autopsy, or the future of the final consultation. The main 3 titles that I will go over is briefly recognize autopsy as an option during end-of-life discussions and as the final consultation. Just an introduction of what is an autopsy and how we go about this procedure. The second point is that the ethical issues that are related to the autopsy and within the postmortem period, how it might be similar or different to antemortem or other procedures performed in the postmortem period. And at the end, and the last focus would be the possible future directions of autopsy. First part, and then also sometimes let's go back. Sometimes I may call it autopsy or postmortem examination. These are synonyms. The way I look at autopsy is similar to a diary, basically a diary of life, how different diseases and different pathophysiology had changed the way the organ looks compared to normal. And just a very similar idea would be a real diary. So the diary of a young girl, which is probably one of the most famous, if not the most famous books, or specifically diaries, by Anne Frank. And I'd like to use the quote she used in her book, "I want to go on living even after my death." And to me that is very similar to autopsy, because the information that we gain after death with regard the deceased, their family, or to the community, or as I would see it as a donation to scientists, a donation to clinicians, a donation to pathologists, and the trainees that are involved in autopsy. It is definitely a way to go on living, really. And so, a diary of life, a diary of morbidity and mortality. The word autopsy itself comes from the Greek autos, opsis, means to see with one's own eyes. And so that would be something that we would compare to, let's say, radiology, because you are going to read a picture and not directly. So this is something that you see directly. You see the changes directly, whether it's down a microscope or with your eyes directly, but you see the changes as they are. So what do we see with our eyes? We see mechanisms of disease, different, pathophysiology and changes that happen to different organs. We can confirm previous diseases. We can discover new diseases. We can identify mortality and morbidity within the deceased. Also, as I said, it helps teaching. It helps teaching healthcare students, medical students, non-pathology residents, and obviously future pathologists. What does a pathologist do? The pathologist, first of all, make sure that they have consent, or they have authority in the case of forensic examination. They make sure that they are safe while performing the examination, and they perform the examination itself. The reason I have examination very early on is because sometimes when this is related to forensic examination, many times the examination will start by viewing the body at the scene of death, and then again, but we're used to mostly in medicine having examination or physical examination is something that we would do after we take the history. It's just that in some instances it may come before. Again, I have history, imaging, and laboratory tests on the same line. The reason is that in general medicine, we take history first, and then we have a differential diagnosis, we do an examination, then we do imaging and laboratory tests. Our patient may have the history taken already, and also the imaging and laboratory tests may be part of that history, and may be something that you would look up prior to even starting the examination. It also assists in the examination. So if you can see on, let's say, one of the radiology, let's say the CT scan, that there's a certain lesion within a certain organ, it may guide your examination. So that's the difference. Many times in medicine, the general idea is you do history first, then you have a differential diagnosis, then you do your physical examination, and then you start ordering tests, not the other way around. But in autopsy, it may be that way. The next step is to do a physical examination. Our physical examination is formally labeled as, entitled external examination, meaning that it is an examination of the external part of the body. However, in healthcare, it is called physical examination. That is the formal label. The next step is a surgical examination, which we call internal examination, meaning that this is an examination of the organs after we incise the body, after we open the chest and abdomen. And the last step is to report, communicate, and make recommendation, meaning that you give a report of what procedure you've done, you give your findings, your differential diagnosis, your discussion, and you make sure that this report is sent or communicated to the let's say, the family physician, the ordering physician, and you make recommendations regarding your findings. So it may be to be referred to clinical genetics, it may be certain types of disease or certain types of, let's say, communicable diseases need to be reported in a certain way to a certain agency. Oncological diagnosis also needs to be reported, let's say, to the cancer agency here in Alberta. So that's regard reporting. And then we talked about safety, which is something we probably don't have to get into in depth. However, personal protective equipment is required to perform these examination, and definitely one of the, I think, positive things that happened, if any, due to COVID, is that this personal protective equipment became readily available, and it became, it is not a struggle to convince administration the importance of this type of protection for the individuals involved in these procedures. Oh yeah, so a worksheet, so what does a pathologist do? Part of it is the procedure itself. So we do have a template or checklist that we go through involving you know, the information that we, demographics of the patient, but also who is attending. Is this autopsy a complete or limited type autopsy? Are we allowed to retain for, is there consent for retention for research or education or none? And if any other tests other than the histology is performed. So photography, cultures, electron microscopy, research, sampling if there's consent, toxicology, biochemistry, and radiology. Then we start our external examination. As I said, external examination is what we call in healthcare a physical examination, and we divide the different areas examined. So we'll examine in the beginning the sex, age, race, body habitus, rigor mortis, liver mortis. So the rigor mortis, liver mortis is basically just to show the postmortem changes within the body. And then if there's any evidence of medical intervention, so like intubation, IV lines, CPR, etc. And then if there's evidence of organ donation, we just list that because that procedure happens before any autopsy examination. And then we do the examination, we divide it into limbs, back, any scars, identifying markers like marks like tattoos, and any personal items. Then we start examining the head and neck, so the skin, hair color, iris color, dentition. Then we do the chest examination or thorax, breast examination, abdomen, external genitalia. And that completes the external examination. And one of the things, the diagram, as the diagram shows, is the back examination. It's a little bit more difficult. As you can imagine, the body is lying on a table, so this is something that you need another person to help out with. Other areas I think that some people may forget are any orifices, especially like a nose, ear, mouth, also the axilla, and then the pelvic area, anal area, and buttock area on the back, between the webs of the fingers and the toes. These are areas that behind the ears. After that, depending on the consent, we'll do an internal examination. And the reason I say that is because the internal examination requires incision. And our incision is a wide incision between the shoulders and the chest, and then down to the pelvis. The reason this is performed is development of the autopsy is in a way that you will be able to have an open casket or a wake, or wake funeral, and so in these cases the body will be clothed, and so that the incisions are hidden beneath. The brain, the head incision is a post-auricular incision, so from behind the ear to the back of the top of the head on both sides. So if you can imagine a body laying down, the incision would be hidden if there is hair and behind the ears. So also the incision for the scalp to gain access to the brain is also not going to impede a wake or an open casket funeral. So those, and so the main reason, as I said, for consent is the internal examination. Internal examination, we examine the body cavities, so the thorax, the abdomen, the pelvis, and then we also examine each of the systems on its own, so the cardiac or cardiovascular system, and then the respiratory system, or the lungs, and then we examine the digestive system, so from the esophagus, stomach, duodenum, jejunum, ileum, entire colon to the sigmoid rectum and anus, and then we examine the hepatobiliary system, so the pancreas, gallbladder, and liver. Then we go to the genitourinary system, so the kidneys, ureters, bladder, prostate, and then the pelvic organs, so the uterus, fallopian tubes, ovaries, and cervix and vagina. And then we examine the endocrine system, so the adrenal glands and thyroid, parathyroid. We examine the reticuloendothelial system, so the spleen, thymus if it is still not involuted, and then the bone marrow and lymph nodes. And we examine the central nervous system, usually done by, and at least in our institute, done by a neuropathologist. We'll examine the brain, and if needed, the spinal cord. And in the end, we have a preliminary findings or diagnoses of the autopsy summarized. Then we submit our different blocks or cassettes or slides for microscopic examination. The way I view the autopsy is in a way a hidden diagnosis, or a diagnosis that has not been seen yet many of the times. So many of the diagnoses or the maybe non-lethal or the diseases that have presented in a non-common way, so a non-common pathway of signs and symptoms. So when we perform the autopsy, each of the organs will be examined, and if there's any maybe benign or atypical presentation of any disease, it will show. So it's very similar to what this painter labeled as the future truth lies in a well, having been killed by liars and actors. And in this case, it is very similar to the autopsy in a way that the diagnoses are not, I would say, buried with the body. Then the painter goes on in the next painting or the next sequence of the same story. Truth, her mirror, and the well. The reason I find that very similar to autopsy is because the original microscope had a mirror to reflect light. Currently we use, just an electrical bulb, but the mirror reflected the light onto the slide in our case and shows the diagnoses. And then once the pathologist has identified the disease, truth is now known, and so that is very similar to how the painter has chose to reflect that the time that these the paintings were made, a time where I guess for the lack of or for a similar, more simple wording, fake news is now revealed. So what does it mean to see with one's own eyes? Meaning that once the body has been exposed or incised, you'll be able to see. See the arrow. So the lungs. So this is the left lung. This is the right lung, covered partially by the heart, which has been reflected. So this is the posterior wall of the heart. This is just for measurement. These are in centimeters, and then we can see the liver here and the stomach. And then we examine each of the organs. So here we're measuring the anterior wall of the left ventricle after the heart has been opened. So here there's enlargement of the left ventricle wall. The samples are put in formalin and then made into blocks and slides so that we can examine under the microscope. This is another way, if you remember, or a comparison slide. The first slide, once we opened the chest wall, you could see the lung directly. Whereas here, once we remove the chest wall, the lungs are encased with mesothelial plaques or mesothelial hyperplasia. In this case of asbestosis or worker compensation case, where asbestos has caused these plaques to encase the lung, makes it difficult for the lungs to move freely. And under the microscope, you're able to see, so let's see, in this case, you can see the nucleus of a macrophage engulfing, in this case, Pearl's Prussian blue stain. It will stain the iron around the asbestos fiber blue. Our macrophage nucleus is dark pink and the cytoplasm is light pink, and you can see it's trying to engulf the asbestos body. We don't see the asbestos body directly. We see the iron encasing the asbestos body. And so in this case, again, you can see the macrophage. It also has engulfed carbonaceous material or anthracosis, which is something, if you're any kind of smoke, whether it's cigarette or other types of personal smoking, or it's forest fires, or if you work as a, let's say in an industry that has a lot of smoke related, let's say petrochemical or in the industry, any other industry, you will get these darker pigment. And here you can see the fiber centrally, whereas in other areas you can see the link between the different, like over here. So sort of like beads on a is it beads on the thread or a beads on a string? I forget the saying. Could be one or the other. But it's also like a rosary or a misbah, or depending on your culture, what you call that. So that's the similar structure. So in this case, the asbestos thread or the asbestos material is the thread that keeps the beads together in one piece. And in this case, once you've seen enough of these, then you will be able, or that the deceased, the family of the deceased would be able to use this as a case as for worker compensation. In another case, the slide also showed, and even after, I would say at least 10 days to 2 weeks, we did the autopsy in this case. And we took sections from different organs, and we found melanoma in most of the organs, including the heart, the lung, the adrenal, the kidney, the liver, the spleen. We found the person had been diagnosed with melanoma previously, more than 8 years ago, but was treated. But it had came back in an atypical presentation. And you can see in these islands of melanoma in the cardiac muscle. And you can see the neoplastic cells basically replacing and invading into the normal cardiac muscle. And without microscopy, it would be difficult, because on gross, it looked like almost post-mortem change. It was very difficult to identify grossly, but definitely under the microscope became very obvious. In this case, this person presented with an atypical presentation of pneumonia, was not responding to antibiotics. And you can see the section of the lung. This objective is not obvious, but when you look at higher objective, you can see that the alveoli are replaced by neoplastic cells secreting mucin. This would look on gross and on radiology very similar, because the mucin is not very different in consistency than pus from pneumonia. And the cells are not destroying the alveoli, but they are lining them. And so there's not enough destruction to see like changes grossly by eye or by radiology. And even at low power, it is very confusing, but at high power, it's obvious. I think these cases were also atypical presentations of different disease. And I think that the interesting thing about this is also the different types of special stains that we can see, and immunohistochemistry that helps us see the different cells and different pathology in different ways. So in this case, this patient had had a blood clot, and so you can see that they presented as pneumonia also. But when you look at the pulmonary artery, you can see that there is a clot, and then if you use MSB stain, Marsh's scarlet blue stain, you can see that there are different layers. So layers of platelets, layers of fibrin and red blood cells. In this case, the red blood cells are yellow. The pale are the platelet, and the fibrin is the pink or red color. Same. And then PAH shows similar but not as well. P61 shows the platelets, and you can see the platelets are also sort of in lines or in aggregates. And these are very similar to the lines that were described by Dr. Zahn. Reminds me of the fields that you see near the Edmonton airport, or also when we were kids, we liked the mixed peanut butter and jelly, I think sort of Goober or something like that. But it looks like very similar to that. Horizontal lines, similar to what is seen. It's just another blood clot, the same patient, another blood clot in different stains, proving that is antemortem, and that's the reason of that, the different stains order. In this next case, this is a young patient with post-aortic valve surgery, and we can see with under the microscope with Marsh's colored blue, you can see the contraction band necrosis within the cardiac muscle. This means that there is myocardial infarction. Same with Mulvat stain. It's a little bit more difficult to see. And PTAH is also another stain that you can use. You can see, compare the darker normal with homogeneous color with other areas where it has pale areas and more darker areas. And these are the contraction band necrosis in cardiac muscle. So that's an acute MI, or well, I guess in the community they would call it a heart attack. Also, you can use C4D and higher power. You can see it lights up the necrotic cells. This is another area showing, or this is the difference between MSB showing contraction bands in pink, whereas in PTAH, in Mulvat stain is just a dark purple on Mulvat. And this is just to compare on H&E how difficult it is to see it, because there's only two colors instead of more. So everything is either pink or blue, and it's very difficult to identify acute myocardial infarction. The next case is another atypical presentation. In this case, is post second surgery, cardiac surgery. So they had to go back, remove a prostatic valve in this case, and then the patient, because the patient had that infection within the prostatic valve, they had but because they were given antibiotics previously, so they had a pseudoculture negative endocarditis. When you go and see sections of the heart, you can see similar areas of fibrosis in different stains. So the old myocardial infarction, which is a scar, you can see on Mulvat is yellow, and then on MSB is a light blue stain. Acute infarction shows loss of pink staining in the middle with hemorrhage. And if you use C4D, you have block positivity within the myocardial sites. Same patient, you can see because the patient had pulmonary hypertension secondary to their heart disease, you can see the abnormally the abnormal arteries within the lung. And you can see the abnormal elastin stain around the artery. Later on, the patient deteriorated and went into diffuse alveolar damage within the lung, and you can see the on MSD, you can see the hyaline within the alveoli. Same patient, and due to heart failure, you can see the patient on iron stain, or you can see the macrophages engulfing iron within the lung. Most of the alveoli are full of macrophages. These are called heart failure cells. This is another area of fibrosis within the heart. And because the patient was in heart failure, you can see that the liver in this section shows a loss of staining around especially around the central vein. And then there's around the portal tracts, the staining is much more obvious. And at higher power, you can see a contrast between the normal staining and then the congestion in this area. So the hepatocytes and the red blood cells on MSD are yellow. As the yellow increases, or the red blood cells increase, so that's more congested because of the heart is not working, right? And so you can see an increase of yellow, loss of staining of the hepatocytes, right? And so you can see that that's congestive hepatopathy due to heart failure. And in the spleen, we found an abscess, just to show that the cultures were negative, but you can see because of the antibiotic use masking the cultures that they had antemortem. You can see that on ground stain, if you focus on the same macrophage right here. On H&E, it would be difficult to see the abscess in the spleen. It would be difficult to see the type of microbe or bacteria, but then when you do a gram stain, it will change the way you're able to see. So here you see a lot of necrosis, you see some nuclei, but not much because of the necrosis. So very few nuclei, that's the only thing that you can see as different. So you see nuclei and you see necrosis, and the cytoplasm of cells is kind of difficult to differentiate, but that's mainly what you see. When you use a gram stain, you'll see the gram positive cocci within the macrophage. And so you know that that is an active process, so this is antemortem, and it is a true infection within the abscess. So in this case, in these cases, this is why we say death delights to help the living. So how so? Through these cases, we've maintained quality of patient care, meaning that we are able to compare different antemortem investigations and why they did not show what they were supposed to show. And we were able to identify atypical presentation of different disease. We are able to develop, modify efficacy of treatments through postmortem examination. And as we said, teaching of medical students, pathology residents, non-path residents, and also to make the death certificate more accurate. The reason for this is that in every jurisdiction, every province or state, they will use the information that we write on the medical certificate of death to use for statistics. These statistics are used to identify reasons of morbidity and mortality, in our populations, and therefore that also may assist in budgeting for different types of diseases. So that's why we need to make sure that we have the right diagnoses at death. So this is one of the ways that we can, or one of the ways that the certificate of death is written. And now we'll jump to the consent issues or ethical issues regarding postmortem examination and what that is. So, as I said, that there's two main types of postmortem authorization. There's one for the medical examiner's office, or in other jurisdictions that it could be called coroner's office. And so they have the Fatalities Act in Alberta, which is a list of specific circumstances where the medical examiner has jurisdiction to examine the body, and that is how authorization is obtained. So no consent is required. It is through the authorization of the Fatalities Act. And these are required by law examination. The autopsy that we are talking about is a clinical autopsy and requires the next of kin to agree or to consent for autopsy. And these are the main two different types of examinations for diagnosis pathologists perform after death. And then the family can choose between, let's say, a full autopsy, so they can choose that all organs can be examined, or they can restrict it and say, we only want, let's say, the brain examined, or only the heart examined. Or they can restrict by, let's say, chest only, so thorax only organs, let's say, sometimes. So ethical consideration post-mortem, we need to recognize what legislation is there, if it's changed or it is similar, and if informed consent is required, depending on the type of case. There's also a budget constraint, so who is paying? So the family needs to know if they are going to pay or not. In Alberta, currently, whether it is a forensic or clinical autopsy, the government of Alberta, in one way or another, pays for that. So if it is a medical examiner's case, it will be paid for by that ministry or Ministry of the budget of the Ministry of Justice. Whereas if it is a autopsy under AHS, it will be paid for under AHS. We need to recognize if there's any that the alterations to medical education have affected the way that consent is obtained, because currently many of the physicians obtaining consent have not performed or have not observed an autopsy, and therefore that is one of the differences between many of the procedures, where the procedure is usually taken by someone that is familiar with the procedure. So if someone has an appendectomy to remove their appendix, the general surgeon that is going to perform the procedure will approach the patient or the family and take consent for a procedure that they have done, they have observed, and they are qualified to perform. Whereas in the autopsy, the person that has the most rapport with the family is a person that most likely has not observed, has not performed, and is not qualified to perform the procedure. So that's the main ethical issue here, as the informed consent is a process, and it is continuous. It is not a one-shot signature. So the reason, and so that's the complexity that comes from medical education or healthcare education. Retention of organs, the ethical issues regarding that is regarding research or teaching. As I said in the beginning, that when we consent, we ask the family, are you willing that a certain, let's say a certain research project may be performed on the samples that were taken. These samples are taken for clinical and for diagnoses, but you can also consent if you would like those samples apply also to, let's say, a research project or to medical education, so to teach other healthcare students. Just as a caveat, that doesn't mean those, so that research has to pass the ethical board or ethical committee also. So all those, this is not an ethical committee, it's just that you ask the family, are you willing that these samples be also be used for research? Though that research that we're talking about also has to go through its own procedure, which is ethics boards and everything, right? So that's, it doesn't help with that issue. So all research has to pass ethics boards and then also consent for the use for research. Also, the timing of consent is an issue because many times, people die at any time, and so when you're approaching the family, if it's going to be 2 o'clock in the morning on a Monday, usually the senior physicians may not be available, and so many times a junior physician is going to be the one. And so also if they have not attended an autopsy during their as a student, and so they had less time probably to observe an autopsy after they've graduated also. So it becomes a little bit more difficult for more junior healthcare professionals. That just describes the different times, and it's a picture of Osler, one of the Canadian physicians that helped establish Johns Hopkins. And at that time, I'm pretty sure that pathology was not its own discipline. So any pathology that happened, or any autopsy that happened, would be done by the physician, which would be a general physician. Which is interesting. Oral pathology, you said, oral pathology, so I know that I think it's called oral medicine and pathology, right? And then, so you have your own clinic, and you see your own patients, and you do your own biopsies, and you read the biopsies, which is very interesting. It's a very interesting way to practice. And then I also described the time of my professor, Dr. Chamberlain, and at his time, the medical students would actually attend an autopsy. Now it is medical students attend as like an elective, or as a week of they choose to have a week in pathology, and they can attend an autopsy. But otherwise, other students probably would not have attended. And most of that means most of the residents in other programs would not have attended also. And these residents will become staff, and if they become, let's say, a staff in orthopedic, or in a staff in, let's say, pediatric or family medicine, they may retire without hearing of an autopsy. And to the last point, which is the reason why we're here today. But we needed that introduction just so that we're all on the same page, so we know what we're talking about. What are the possible future directions of autopsy? So currently, as you've seen, we do a gross examination by eye, then we do histology and microbiology. We can do toxicology, mostly in forensic cases, but we can do toxicology, immunohistochemistry, some of the slides that we went over, electron microscopy, especially if you're doing kidney pathology, but postmortem is not probably the preferred electron microscopy tissue because of postmortem changes. We can do molecular and clinical genetics on autopsy, and we can bank tissue for future tests. However, the current postmortem or autopsy examination is not without its flaws. We do work sort of in our own area, so the pathologist tries to work toward the autopsy in their own way. The physician, through requesting autopsy and approaching patients, work in their own way. And the future, which is not something we know 100%, has a lot of things to offer. So what are those things that the future has to offer, or that we can try to guess? What is the future of the autopsy? So some of the things that I thought were important, and maybe you can sort of brainstorm with me what ideas you may have for the autopsy to improve it or to make it faster. So one of the two points I thought that the future may hold for the autopsy: reducing workload, meaning that we would be able to screen some of the cases, so that the percentage of autopsies or full autopsies would be less, let's say. Although in my mind, autopsies are too low as it is. So one thing would be to reduce workload, so perform less autopsies with internal examination or with incision. And the other thing would be to replace human for safety reason, or direct human contact for safety reason or for diagnosis, by using postmortem imaging like MRI and CT scan, robot-assisted surgery, so 3D autopsy reconstruction, and then the last one, which would be implantable devices such as pacemakers and diabetic monitoring. So would we be able to use these? So I think I have it, yeah. So the issues with these would be that we would not see with our own eyes. So that would be one problem if we're going to use radiology. The second thing would be you would still need to perform incisions. So robot-assisted surgery does help with safety, but it increases the cost. But you would still need to get tissue for diagnosis, because the key, I think, to the autopsy is not only to see with one's own eyes, but also is to be able to choose the disease, to know which organ is diseased, to choose the right sample from that organ, and to see it under the microscope with different special stains and immunohistochemistry. So you would still need to take a biopsy in the end. So you would still need to incise the skin. The issue with implantable devices would be that the devices would need to be implanted prior to death. So pacemakers, diabetic monitoring, would we be able to, would people accept that they are monitored 24 hours, similar to pacemakers and diabetic monitoring? So those are the issues that I saw with that. So they may increase safety for the practicing pathologists and the students that are attending, so they would not directly need to touch the body or come in contact with the body. Maybe more students would be willing to attend. The question would be, with regard to diagnosis, this is the reason we do the autopsy, is for accuracy of diagnosis. Is that going to increase or decrease? Is the speed of autopsy going to increase or decrease? Because if you increase the number of procedures performed, then you would decrease the speed. So if we're going to do a CT first, we would have to organize that. That would increase cost. It would also take away or it would compete with living individuals for the same procedure. And then it may delay funeral or other ceremonies that happen after death, depending on the culture. So that is also an issue. And then would that help prevent disease within the family and the community? Would that assist in that or not? And then recording versus privacy, would people allow us to record that? 24 hours monitoring, let's say your breathing, your heartbeat, how that would affect us personally, or for like different issues like insurance, whether it's life insurance, medical insurance, and that kind of thing. But I think that we should work closer together so that the autopsy does give the information that not only the pathologist is advocating, but what the physicians want, what the future want, and what the community wants. What are the things that we're able to adapt would depend on all three of those things. So in the end, we talked about an autopsy as an end-of-life procedure. We talked about the ethical issues issued with autopsy and how it affects the different areas of autopsy and possible future directions. Yeah, thank you. So I think that we could maybe discuss these different issues and how you think autopsy in the future would change. I don't know if anyone has any ideas or questions about the procedure itself or about the future. Yeah.
One question that I have is, you mentioned that currently the autopsy rate in Alberta is very low, 7%. So I imagine that there are not a lot of clinical autopsies which are requested by families. Typically, when a patient passes away, is the possibility of a clinical autopsy something that their physician, their family physician, introduces to them, or is it something that's usually not mentioned so the general population is not aware that it's a possibility?
Yeah, so you did, it's an amazing comment. So the issue, as you said, and from a pathologist's perspective, the autopsy number is low. That 7% includes forensic autopsies. And so it's, clinical autopsy is much lower than that. And so the, because of, as I said, maybe there's a feeling of, by our modern current physician, whether family doctor or specialist, that the current technology and development of investigation is enough not to request an autopsy. And so that we have done as much as we can as far as the current technology, the current tests and investigations, that there will that nothing will show at autopsy, which is incorrect. So that these papers have been published since the 60s, starting, I would say, the golden era of antemortem, postmortem complaints started with Goldman in the 60s and 70s and 80s, and he started a series of papers showing that autopsy will continue to show new diagnoses, whether it is related to morbidity or disease other than that related to morbidity, mortality and morbidity. And so the diagnosis or the new technology does show very high accuracy with typical presentations, but I think you've probably heard it many times where they say not all diseases read books, and so many diseases present atypically. And if they present that way, there's no no obvious pathway or no easy pathway to investigate. And at the best, the investigation is delayed. So what would happen in many of these cases, that the correct pathway to investigate a certain presentation is always taken by the physician. The problem is that the signs and symptoms that they have appreciated are not for the disease that they think it is. And so we're always taught to say, to think that, okay, what are the signs and symptoms? What are, according to the signs and symptoms, what do you think the disease is? So let's test those diseases. But the problem is when the signs and symptoms are atypical, then you will not go down that pathway. And so that gives us room to say, okay, so in these atypical presentations, what is the new, what is a new test that we can do, or that we can invent, or that we can create, so that we can catch these atypical presentations? If we continue to accept that we will just miss the atypical presentation, then we will not invent something. Because if we don't identify it as a problem, why would we make a new test? If we already have it, everything is perfect, so we won't fix it. That's the main idea behind the autopsy, and that's the reason that I feel that autopsy is something hidden in a well. And so if you don't go down, grab the information and bring it out, you will not see it. And so you are correct in saying that the physician that is going to offer the autopsy will not offer it because they already feel that we've achieved everything in life. There is nothing hidden anymore. But the truth is, there is something hidden. And it's not 100%, but it's not zero either. So a lot of the papers show anywhere between like 1.5 up to 28% you can find, depending on how detailed you do the autopsy and if you're including diseases not directly related to death. So it may be something that was ignored because at the time it was not causing a deadly disease. So it had nothing to do with the mortality at the time. So we're going to ignore that, or is thought to be benign, let's say. So yeah, so so the first part was about the percentage. Yes, it is low. The second part is, are physicians not offering? They are, yes, they are not offering. So a recent study, I think it was either this year or last year, came out, showed that 2 to 3 times higher was when the family was offered an autopsy was accepted 2 to 3 times more than if it was not offered. There are families that present asking for an autopsy, so that's a different issue. But when the family was approached, and it is a difficult time to approach a family because you're approaching the family when their loved one has just died, and so it is a difficult time to approach. But when approached, the autopsy increased 2 to 3 times more. So it is also an issue that pathologists need to try to advocate and reach to a larger audience of healthcare professionals.
There's something that happened recently that I found fascinating. In the hospital's celebration of Truth and Reconciliation Day, they had an ethics session. And it was like 2 hours, it was long. And, you know, the dean was there and I was there. They said all the medical leaders should be there. And toward the end, it was quite emotional. It was about the death, that seems like the unnecessary death of this person. And then, you know, you've got all these cultural issues of like respect and and one of our pathologists went to the microphone and talked about, in their world, they would want an anatomical diagnosis. They want to know why the patient died. And basically the people at the front of the room said, we don't care what the autopsy showed. You know, I think part of it was one of timing, that you were sort of toward the very end. But there's an opportunity there. This is presumably, we're going to keep doing this. We'll have a Truth and Reconciliation Day. The hospital will feel that everybody should be there, especially the leaders and so on. And pathology could play an important role someday by having a case where actually pathology serves to bring everybody together and, you know, has everybody more satisfied when they leave the room, you know? That is one way this could work. Okay, well, we were looking for truth, and the autopsy gave us truth. Yeah.
True.
Yeah.
Yeah.
So I see that as a future goal. It's not the only goal, but it's something local and kind of meaningful, and if you're there, you really feel you've been through a process when it's done and so on. And maybe it could be made better by having pathology directly involved in the planning, you know, pick a case where pathology kind of links everybody together, and yeah, this could be a thing.
Definitely.
Yeah.
Like as a future direction, you're saying, your thought is that there's already too little autopsies being performed.
Correct.
So why not instead try to get more people that can perform autopsies, and to emphasize their need and to attract individuals to study, you can show like the benefit of research in people who have passed. Because I know, like, even as I'm doing research, I do it in cell models, which is like the beginning, right? And then you want to do animal, and then human is like gold standard. But there's so many cases where, just like we're talking about, you can't see it until they've passed. And so maybe exactly like this, with the Truth and Reconciliation idea, you can emphasize the need for, hey, if we actually perform more autopsies, we could prevent even more deaths, rather than, for example, when there's drugs that are developed that turn out to have very bad outcomes, typically a lot of people pass before we actually figure out that, hey, this is the problem. But in this case, if they're being performed more regularly, we could find it.
But wouldn't you say, let's think about this course, Technology and the Future of Medicine. We also are kind of a fringe interest, right? Most people are not looking to take such a course, right? And the future orientation, most normal humans are sort of like politicians. They care about the next 2 or 3 years, or until they graduate or the next big epoch, and 0 after that. So like in this course, we're talking about what are things that we like 5, 10, 20, 50, 100 years from now. And the resistance to that is sort of like the resistance to performing an autopsy. So you say, well, why don't we get a major effort to improve interest in the autopsy? Well, what would you think about a major effort improving interest in the future? You know, the long-range consequential future, whether there are humans on Earth, you know, whether there are many multi-planetary species, so on, you know. And then you could imagine bringing those two initiatives together, right? Make increasing the autopsy a part of the rational planning of how you're going to approach the future.
I think that's one of the things I noticed in this class is that the reason that you have high yield points for the students in the class and the TAs and solutions is the same reason that you signed up for this class. So you're a biased group of students that came, that already has in their mind how to improve, right? So all the points from the, this is my 3rd or 4th, I can't remember. But every time I came, it was the same, it was sort of like too comfortable for me. Because I'm used to being attacked.
Nobody's challenging.
No, not only they are not challenging, they are agreeing and giving more solutions. And so it is also, and it's because as you said, that it is you are here because of a reason. You signed up because you want to improve. So you're looking at this, okay, this is a scientific method. So why don't we do it? And if we do it, why don't we do it more? And why don't we benefit from it for medications, let's say? And future, newer medications, how do we know what they do? And what is the, you know, did they, as you said, are they improving? Are they, let's say, taking out the cancer cells? Are they hitting other organs? And so that is a very interesting thing. And that reminds me, it's like why we have examinations for a license or for any type of schooling, is to measure. And autopsy is a measurement. Like if I said, okay, let's do like we do with autopsy, right? We'll do 7% of the students can take an exam, and 93%.
So Syria was kind of like that. I went to Syria in 2004. There are long periods of time when you can't go to Syria and get back out, but that was a time when you could go there, and it was before all the really bad things happened. But it's sort of so many things you just assume about life were not present there. Like there didn't seem to be public restrooms, period. And so you gotta think about that. You would use the restroom at home and go out and do your business.
And then get back fast.
Come back home, right. And the people in charge of things were not experts. They were people who had bribed their way or through family and religious ties been chosen because the size of the bribe or the people they were related to, right? So no one in charge of anything is an expert. So basically the whole country, nobody knows what they're doing, right? And there are many countries like that. I'm not just picking on Syria. I'm saying this is not unique. Okay, and what about laws? really all that counts at that time was what the ruler wants. So laws are like theories. You know, yeah, sure there's a law, but nobody pays attention to that law, because that law the ruler doesn't care about. Now there's this other obscure law over here that the ruler really cares about. You better pay attention to that one. It was very, very interesting. But the other thing that happened, when you, in the course of your life, enter a new situation and have conversations and plan things and so on, you'd like to think the conversations are going somewhere, right? So I talked with them about how, you know what I talked to them about, like video lectures, right? We could provide education to them, and they could, to some extent, educate us, and so on. And so think in your mind why that conversation was a waste of time. It was a waste of time because Syria was part of the, quotes, axis of evil. And so all the big companies in the world could not provide the bridging technology for teleconferencing because it was illegal to do that. Countries that were part of the axis of evil, right? But the other thing, like certain things that I do worked better there than ever before. I brought my Sony Aibo robotic dog there, and when I spoke, the dog sort of walked back and forth in front of the podium. It was well lit, the dog could see where he was going. He was happy, I was happy, and the audience was just enthralled. It was like the best performance ever of Kim Soles and his robotic dog. And it was immediately apparent that this has been a big success. But also, it was like an alternative universe, right? It didn't matter how I performed there, because like the linkage between Syria and every other country is so very marginal, right? And like, oh, yeah, anyway, that was interesting.
Yeah, it was, because I think that, as you said, like if you cannot provide the service, because we said that, like, why don't we increase the service, right? Or use technology to increase the service. So, I think that, as you said, you would have to convince the higher administration or the leaders in the administrations,
Right.
the healthcare and in education, that this is an important procedure to perform, and if not, then and I guess I would say that if you could convince them, then you could increase the percentages and therefore show the importance. But if you are not able to increase the funding, then maybe even discussing the issue or the future of that issue is not going to be fruitful. Definitely.
So imagine dreaming about things that you think could never happen. Like, as a kidney pathologist, I probably think that I would never be a university president because they would never choose somebody like me. So in Syria, we were visiting there because the president of the university was a kidney pathologist. I said, wow, that's amazing. Yeah, but as I've said, because of Syria's situation with the rest of the world, there weren't real benefits. It's just he was interested. Yeah. So the president of the university asked me to come. I went with my children, and it was fantastic for them because imagine people very high ranked giving your kids tours of the country. That's basically what was happening. Like, they would ordinarily be assigned to do something else for the country. But when we were there, they were giving tours to Dr. Soles's kids, you know? Yeah. So it was either the most important time in my life or the least, you know? Possibly it's simply a major distraction that all those things happened because none of them could go anywhere. If my kids made friends in the country, those are not sustainable friendships. The one difficult conversation I had was, and it was where we had a witness, and I know it's bad news. So it was like, can we talk about something? I said, I have a bank account in a Canadian bank, and so I'd like to give you some money to put in my bank account. And I want a witness, you know, and so on. So do this financial transaction. Yeah, and it wasn't like a huge amount. It was like, I don't know, $500 or something. So I did it. But yeah, it's kind of like when I went to Tasmania. Do you know where that is? Yeah, it's an island off Australia, separated enough where they have different wildlife, right? The Tasmanian devil, which is a cartoon character, but is real, and they bite each other's faces and all these sorts of, I mean, it's really weird. But yeah, so it's sort of like the trip to Syria, right? I went there, and I was there for a short time, but there was a major meeting there, and I held an important leadership role and stuff. So the cab driver who took me to my hotel when I arrived, he said, well, couldn't I keep giving you trips while you're here? I said, sure, yeah. So imagine now what happened on the last trip, right? So Tasmania is kind of an isolated place. And he had a kid with learning disorder, and he wanted to get therapy for his child with learning disorder. So on the last trip back to the plane, right, he tried to negotiate with me, like, you know, whether there's drugs that could be used for this learning disorder and stuff. And it's not like, that's not my area. I'm a kidney pathologist, you know, I'm not into drug therapy for learning disorder. But don't you think it was kind of predictable that that would happen? Because I represented an opportunity for you. So I'm gonna have it again. Why not go for it, you know? And you can imagine a lot of other go for it kind of things, you know? But, yeah, so there was a certain time, and there's a video about this, so doing risky things for the ISN, International Society of Nephrology, so they were planning a major conference in Jerusalem, yeah. And so in the planning for that, I had proposed a presentation on international disaster relief. And you say, well, it's not really a kidney talk. Well, it kind of is. It overlaps with kidney, but it's not something a lot of kidney people think about. And so I was criticized, and criticized enough in this secret meeting that the word came back to me. And the criticism was, Dr. Soles just sits in his chairman's office in Edmonton, Alberta, Canada, and sends other people in this disaster relief task force out to put their lives at risk to try to dialyze patients with kidney failure after earthquakes and stuff like that, and never puts himself at risk. Well, this is easy to fix, actually. I can now start doing things that make it look, so yeah. So I went to Nigeria after a major mass poisoning there. I mean, it was directly related to like international disaster relief. It's sort of like what started the FDA in the United States. It was a mass poisoning, very similar to what happened. So anyway, I went there. I didn't see another white person for a week. Understood I had to bribe my way out. I'd never bribed it before, but I thought, well, you can learn. You can learn how to bribe your way out. Yeah. So I got a Christmas pudding. I thought that was going to be the bribe. Gradually, I realized that's not going to work. But what worked was I was carrying my stuff in a paper bag. Bag got ripped. And this made me upset, you know. So people were saying, oh, you know, your salary is so much higher than mine. Can't you just leave a little bit of money behind? It'd be so much for me and it'd hardly mean anything to you, and so on. And because my bag was ripped, I said, no, I'm sorry that your salary is so low. I can't help you, I'm sorry. And the guy just smiled and said, okay. So I realized when I got to the pressure gate that no one else had dared to say no. All the other white people, I hadn't seen any white people, but when I saw them there getting ready to leave, they had all like given away all their earthly possessions. They thought that was the only way to get out of Nigeria. And I had found a secret that you could just say no. Okay. Yeah. But is that some big life lesson? No, I think it's highly specific, right? In another setting, there would be no alternatives, right? Yeah, yeah. So anyway, what can I tell you? Life is sort of like that.
I'm wondering if I'm going to be able to apply that lesson somewhere.
Yeah, I mean, you can put it in the category of things that can happen. There are also a lot of other things that can happen. Yeah. So, right. Okay, well, thank you very much.
Thank you for having me.
Yeah.
Always enjoy.
I think we have seen you for the third time. I think Mr. Dana were in the same class when we started, so I think we both teams.
Yeah, I think it was the